everyone for joining for today's training hosted by Max for Moms, Acute Management of Withdrawal in Pregnancy. So my name is Tracy Summer, and I'm going to be helping to facilitate today's webinar. As I mentioned, today's training is hosted by Max for Moms. We are a program that supports prescribers and their practices across the state in addressing the needs of pregnant and postpartum patients with substance use disorders or questions about pain management. And all of our services are free. Phone consultation for clinical questions, help with finding resources and information, trainings such as today's webinar, as well as our tele-echo clinics. And Marcielle is on our team as well, and she put our information into the chat, and you can contact us at any time. Before we dive in, I'm going to go over some housekeeping items and the process to earn credit for today's training. So you can use the chat during today's webinar if you do have any questions, and there will be time at the end for questions. As you heard at the beginning, today's webinar is being recorded, and that, as well as a copy of the slides, will be uploaded to our website within 1 week. Earning credit for today's training, I know that is of great interest. You do need to be online for the full duration of today's webinar in order to receive CME or CEU. Immediately after today's session, you will be marked present in Oasis if you have been on for the full hour, and you'll be able to log into your portal, complete your evaluation survey, and then you'll be able to access your CME or CEU certificate directly from Oasis. You do need to complete that evaluation survey within 7 days in order to get credit. I'm now happy to introduce our presenter for today. So today we have with us Dr. Katie Mark. Dr. Mark is an obstetrician and gynecologist who holds dual board certification in obstetrics and gynecology, as well as addiction medicine. Her research and clinical interests center around the intersection of reproductive health and substance use disorders. She is the medical director of the University of Maryland Women's Health Center at Penn, and the director of the Substance Use in Pregnancy and Parenting Parenting Outpatient and Treatment Program, also called the Support Practice at the university. In addition to her practice, she has an ambulatory gynecology practice at the University of Maryland, and that is where she cares for people with gynecological needs throughout their lifespan. She performs surgeries at the University of Maryland downtown and midtown campuses, as well as the Veterans Administration Hospital in Baltimore, Maryland. That certainly does not cover everything, Dr. Mark. Thank you so much for joining us today. I'm now happy to pass it on to you. So we are not able to hear you. I don't know if that's on my end.
Can you hear me now?
Yes.
Okay. Sorry, I had to pivot the computer I was at. Just for some reason, the screen wasn't working or the camera wasn't working. But here we are. I'm glad you can see and hear me now.
Yes.
So just one moment. Let me put
Sure.
As long as we've all been living on Zoom, I always have a hard time figuring out how to share the screen and look at the screen at the same time.
That's okay.
So can you see just my presentation slide right now?
Yes.
Okay, fabulous. Well, thank you for that lovely introduction, Tracy.
Sure.
And thank you for everybody for being here. So we're going to talk about managing acute withdrawal in pregnancy. This is one of the more common calls that we get on the Max line. So as Tracy said, I'm a consultant for Max for Moms, and it's a one line where you can call and ask any questions about pregnant or postpartum people with substance use disorders, and we will help you walk you through it. But hopefully this will answer some of the questions that you may already have, because we get asked these frequently. The learning objectives are we're going to review signs and symptoms of acute opioid withdrawal in pregnancy. We're going to explore pregnancy-specific risks and concerns, and then discuss treatment options. So I wanted to start with a case. This is made up, but it's a conglomeration of many people that I've seen over the years. Mia is a 24-year-old G3P1101. She's at 37 weeks. She comes to the OB unit and is seen in triage with a complaint of nausea, diarrhea, subjective fevers, and malaise, just like general body aches, not feeling well. She has limited prenatal care and just moved to the area from another state. She reports that she has had preeclampsia in a previous pregnancy. She's taken to a triage room and asked to undress, put on a gown, and leave a urine sample. The nurse takes her vital signs and notes that her blood pressure is elevated at 155/98. The fetal heart rate monitoring is reassuring, and the triage nurse goes through a series of screening questions, during which the patient reports that she has recent opioid use. About an hour after she arrives, the triage physician, Dr. A, comes to evaluate the patient. The provider notes that she is resting comfortably but not engaging in conversation. Dr. A explains to Mia that she's concerned about preeclampsia because of her elevated blood pressures, and she orders continuous fetal monitoring, labs, and blood pressures every 15 minutes. The triage nurse has difficulty drawing blood from the patient and calls phlebotomy. The labs are drawn 2 hours after arrival to labor and delivery and sent to the lab. 2 hours after that, so now 4 hours after she originally arrived, the labs return and Dr. A notes that Mia has mildly elevated liver function tests and protein in her urine. The triage nurse lets Dr. A know that Mia is quote unquote refusing blood pressure monitoring and has removed her fetal heart rate monitor. Dr. A enters the room to evaluate Mia, notes that Mia is restless and diaphoretic. Mia tells Dr. A that she has increasing abdominal pain. Dr. A performs an ultrasound and reassures Mia that the baby is healthy and there are no signs of placental abruption or other obstetric emergency. And Dr. A performs a cervical exam, finds that Mia is dilated, and tells her that she is likely in early labor, and that's the cause of her abdominal pain. The doctor then leaves the room to put in the admission orders and asks the nurse to repeat the blood pressure and replace the fetal heart rate monitor. The nurse attempts to replace the monitor, but Mia takes it off, says it's painful. The nurse just continues to repeat how important it is to monitor the baby. When Dr. A returns to the room, now 5 hours after arrival to the unit, to consent Mia for delivery, Mia is increasingly agitated and asking to leave. Dr. A explains the risks of leaving against medical advice, including maternal stroke, seizure, placental abruption, and neonatal death. Mia signs the paper, accepts the risks, and leaves. So, given that you are here for a discussion about withdrawal in pregnancy, I'm sure you knew where we were going with this, but let's kind of review how this case was managed. So the presenting complaint was abdominal pain, subjective fevers, body aches, malaise. These concerns really weren't addressed at all. Like the conglomeration of these concerns weren't really addressed. The patient screened positive for substance use. She told the nurse that she had recently used opioids, and this was not further explored. She had an elevated blood pressure, and that this was assumed to be preeclampsia or a hypertensive disorder of pregnancy. She got increasingly agitated, and instead of addressing this, they just kept telling her, you need to be monitored, we need to check your blood pressure, it's risky to you if you leave, and kept telling her the risks of her refusal. So you may, and those of you who have heard me speak before probably know that my favorite thing to talk about is bias, because it is just so ubiquitous, and we all have it. And so I think this case shows a really good example of multiple different types of bias. So one is availability bias, where we prioritize the information that most easily comes to mind. So most obstetricians are used to seeing preeclampsia, labor, high blood pressure, hypertensive disorders of pregnancy. So that's the first thing we think of when we see those signs. Confirmation bias, then we seek out information that agrees with our initial assessment, our initial opinion, and tend to pay less attention to the other things that don't necessarily agree with our initial diagnosis. Anchoring bias, again, these all play together, but it's prematurely favoring a specific diagnosis. So you decide early this is the diagnosis. Your confirmation bias just has you continuously look for information that confirms that. Framing bias is very important in this situation, and for people with substance use disorders in general. But framing bias is when information is weighed differently based on how it's presented. So when the nurse comes to the triage doctor and says, she's irritable, she's refusing monitoring, she won't let us check on the baby, or she's not engaging in conversation, or she's argumentative. All those things are framing bias that the next person that comes in to see the patient is analyzing that information under the framework that was presented to them. And then attentional bias is just when we tend to direct our attention to some pieces of information and ignore other pieces. So obviously, the issue in this case is that they did not recognize her withdrawal, and it worsened over the time that she was there waiting for the workup for the other things that they were finding. So how do we recognize withdrawal? Well, there are some early symptoms, some early stages and later stages. Oftentimes these don't exactly follow the script, and they don't happen in a exactly sequential fashion. But earlier withdrawal can be lacrimation and rhinorrhea. Their eyes and nose are watering. They might feel sweaty. They might be telling you that they're feeling hot flashes. They might be yawning. They might be restless. And some of the yawning and restlessness oftentimes get misinterpreted as them being not engaged in the conversation. The signs that they can have, things that you can see, sometimes they will have dilated pupils or piloerection, like they're like goosebumps and their hair is standing up. They may have muscle twitches. They may be complaining of generalized muscle or bone aches, and just generalized abdominal pain, which again, in pregnancy, people have abdominal pain for lots of different reasons, but one of those reasons can be withdrawal. Some of the signs, some additional signs that you might see in their vital signs, they can have tachycardia, increased heart rate, increased blood pressure. They may be breathing really fast. They may actually even have a fever. Oftentimes they report subjective fevers, but they may actually have a fever. They may have nausea, vomiting, refusal to eat. And then as time goes on, they get more GI upset and can have diarrhea and become dehydrated. They can even get hyperglycemic and hypotensive. At first, they're hypertensive, and over time can become hypotensive. The average vital sign changes in somebody who's in acute opioid withdrawal are that the systolic blood pressure increases 15 to 20 points, and the diastolic blood pressure increases about 10, and the pulse will also increase. As they get more and more agitated, sometimes the pulse will increase even more. So these are, you can see how these things would be confused for other things that can happen in pregnancy. So how do we monitor this? Well, there are two scales that I'm going to show you. One is CALS, which is the Clinical Opioid Withdrawal Scale, and then we'll talk in a second about SALS. So CALS takes these vital sign measures into account, looking at their pulse, then whether they're sweating, if they're restless, their pupil size, body aches, runny nose, all these different symptoms that we were discussing, and it gives them an actual number score. Sometimes people use that number score to decide what treatments to give to people, but it is, I think, probably the most useful way to use it is to track over time and see if your interventions are helping. I will caution you that a low CALS score does not necessarily mean that somebody is not in withdrawal, because a lot of these things are subjective. And the time that I see the CALS failing the most is when the patient is very, very uncomfortable, and like at the beginning it said resting comfortably but not engaging in conversation. A lot of times they're actually incredibly uncomfortable, and so they're sort of withdrawing and have a sheet over their head and don't want to talk to anybody, and that gets confused sometimes for them being okay and just not wanting to talk to you. And then sometimes the CALS score will be falsely lowered based on just our inability to really evaluate some of these things. SALS is a subjective opioid withdrawal scale, which is the patient reports these things. So it's not me looking at her to see if she is sweating, but her telling me that she's sweating. And it also takes into account things like feeling anxious or feeling hot flashes, cold sweats, things like that, that aren't always really able to be captured in the CALS score. So I've already mentioned some of this, but things that withdrawal is often mistaken for a mental health crisis. I've seen many times people are extremely agitated, they start to get argumentative, maybe even aggressive, and then it's treated as a mental health crisis. GI distress, because they can get nausea, vomiting, abdominal pain, diarrhea, all those things can be part of withdrawal. It can be confused with an infection because they have a lot of the vital sign changes and even subjective symptoms of an infection, abdominal pain, hot flashes, tachycardia, diaphoresis, and general malaise. These are all things that you often see in infection. Hypertensive disorders of pregnancy, as we've already discussed, the blood pressure can increase. And then malingering is, hopefully no one thinks that that's what it is, but that can happen. And then I mentioned in one of the earlier slides, but I just want to say, because there is a large cortisol release when someone's under this level of stress during withdrawal, they can also have some hyperglycemia too, elevated blood pressures, or I'm sorry, elevated blood glucose. So now that I told you how to identify it, and hopefully we identified it in our case earlier with Mia, what do we do about it? How do we manage it? I could just end my talk here. I won't, but I want everyone to remember that the treatment of opioid withdrawal is opioids. People are withdrawing from opioids, so you give them opioids and they will stop withdrawing. So this sounds like such a simple concept, but I think there's a little bit of cognitive dissonance there sometimes. So whenever you are taking care of someone who is in opioid withdrawal, hopefully you will remember the slide and this very simple statement that they're withdrawing from opioids. They typically need opioids. So what does that mean? What should we be giving them? So acute treatment of opioid withdrawal, you can give full opioid agonists. So this can be something like oxycodone, which is more short acting, methadone, which is longer acting. We'll talk about buprenorphine in a minute. And if in now the day and age of fentanyl, if somebody's been on fentanyl for a long time at high doses, oftentimes you really do need to start with a full opioid agonist, which again can be oxycodone, methadone. It can even be Dilaudid if need be. And usually these things they can take orally. If they can't for some reason, there's IV formulations of Dilaudid and morphine that can be used. All of these are full opioid agonists. They are different potency and different onset and length of action, but all of them, oxycodone, methadone, morphine, and Dilaudid are all full opioid agonists that will help get somebody out of opioid withdrawal. Well, and again, we'll talk about buprenorphine in a few slides. So the full opioid agonists that we were talking about, methadone, fentanyl, Dilaudid, oxycodone, these are all things that are that bind to the opioid receptor and have full activity at the opioid receptor and are the most likely to help immediately treat their withdrawal. Buprenorphine is a partial opioid agonist, and so it also binds to the opioid receptor, but it only has about half as much activity. And so depending on where they are in withdrawal, that may or may not work. And then naloxone is a complete antagonist of the receptor, and so it completely blocks the opioid receptor, so would put someone into withdrawal if you gave them naloxone. So starting with methadone, we're talking about methadone. I'm not saying that is the only thing that you can start with, but talking in this conversation, talking about methadone. Recently, SAMHSA has updated the guidelines, I think in 2024, because they recognized that we were really undertreating a lot of people with methadone. And so they changed their guidance and said that you can start with between 20 and 50 milligrams as your initial dose. And there's not an exact algorithm to pick which dose to start with. If the patient has been on methadone before or knows anything about what their methadone tolerance is, you may want to tend to start a little bit higher. If they're on very high doses of fentanyl, have been using for a long time, then you might want to tend to start on the higher end. But importantly as well, you don't just have to stop there. So when I was first taught this about how to initiate methadone, it was give them 30 milligrams and then you can't give them any more methadone for another 24 hours. But that guidance has changed. And so you can give additional doses of methadone. Particularly, remember, these people are in the hospital. This is in a monitored setting. We're talking about acute withdrawal and labor and delivery. So you can monitor their heart rate, their breathing, and things like that. So you can give them additional doses of methadone up to 10 milligrams every 6 hours. And if for some reason you're concerned about giving them more methadone or higher doses of methadone, you can also give them short-acting opioids. So the concern with methadone is that because it's so long acting, that if you stack too many doses, they may not be really feeling the effects of those for a few hours, and then it can start to cause respiratory depression or or QT prolongation and heart issues. And so if you are not comfortable with increasing the methadone or giving multiple doses of methadone, then you can just give them short-acting opioids. So 5 to 10 milligrams of oxycodone every 4 to 6 hours as needed. Now, I didn't put it on this slide, but some people will titrate these based on the COW score and showing that the COW score is decreasing. And if it's below 8, maybe they don't need more medication. That's okay if that's the way you do it and want to standardize it that way. Personally, I titrate it to their comfort. And so again, I think that the COW score tends to miss some of the experience of withdrawal. And it's great if you see their blood pressure normalizing, their vital signs normalizing, but if the patient is still telling you that they're feeling really sick, then I believe them and give them additional opioids until they feel more comfortable. This is from PCSS. It's basically everything that I told you in the last slide, their summary of the new SAMHSA guidelines. I just wanted you to have this slide if you wanted to see it from PCSS. So there have been, the SAMHSA guidelines don't specifically say that this is for pregnancy, but there have been some studies that have looked at higher dose initiation and more rapid initiation of methadone during pregnancy. And the reason that SAMHSA had this change their guidance is because they recognized we were under treating it. And what we see in the hospital is that people leave against medical advice because they're just like the person in the scenario, Mia, because we're not treating them. They feel very, very sick and they're just getting worse and worse as we're not attending to their withdrawal. And so in this study, they started with 30 milligrams and then gave 10 milligrams every 6 hours. This is within the SAMHSA guidelines. That was their standard titration, and then their more rapid titration, they started with 30 or 40 milligrams and then gave 10 milligrams every 4 hours. And they found in the more rapid initiation group, they had less elopement. And I think the biggest concern about more rapid or higher dose initiation is that are we going to cause people to be over-sedated or to overdose on opioids? And they had 0.5% of one patient in an almost 200 patients series that they did this in this hospital, only 1% required Narcan. And again, remember, they're in the hospital, they're being monitored. This is showing just another hospital's protocol for how they did more rapid initiation. And this hospital did this specifically in order to initiate split dosing, which is what we know oftentimes pregnant people need after discharge. I would say, and this is not dissimilar to the one that I showed you before, they're saying every 4 hours they're giving additional methadone. I would say that I do want you to think about discharge planning. We're going to get to that at the end of this talk. But when you're initially starting the methadone, just think about their current withdrawal, and you don't have to think too much about how this is going to play out with what they're going to be discharged on long term. Our goal immediately is to keep them safe and as comfortable as possible and getting treatment. So we talked about, there should have been a transition slide here today, but we're going to now switch for a moment to talk about buprenorphine. And so methadone, as I said, is a full opioid agonist. Buprenorphine is a partial opioid agonist. And there's a lot of data of the safety of buprenorphine for treatment of opioid use disorder in pregnancy for long-term treatment. But I think everyone's hesitation with buprenorphine is that it can cause precipitated withdrawal, which means that if somebody has a full opioid agonist in their system and you give them a partial opioid agonist, it will competitively bind to the receptors and then they will have lower receptor activity based from the buprenorphine, which if you're changing them rapidly from 100% to 50% of their opioid activity, then that is going to precipitate withdrawal. It's going to make them feel withdrawal, even though you are giving them an opioid. So we're going to talk about how much we really need to worry about that in a moment. But this is the concept of precipitated withdrawal. And as this slide says, the incidence of this, depending on how you define it and what study you look at, is somewhere between 0.8 and 13.4%. But again, precipitated withdrawal is a really wide range of symptoms, so that the ones that say it's over 10% are typically looking at much lower or much more mild symptoms and starting the buprenorphine much closer to the last time of a full opioid agonist use. So there are different ways that we can initiate buprenorphine, and I'm going to give you a couple different protocols. None of them are right or wrong. They're all different options. So because it is a partial agonist, and as we talked about, it can cause precipitated withdrawal, you don't want to start it when you don't want to start one of these more full like the higher dose regimens if somebody is not feeling withdrawal. So again, this talk is about acute management of withdrawal. So if somebody is actively in withdrawal, they're feeling very sick, they have a high cal score, they're telling you that they're withdrawing, then you probably can start buprenorphine on them because they're already having lower receptor activity. That's why they're withdrawing. If somebody came in and just used fentanyl and is not really feeling any symptoms of withdrawal, that's when you have to be a little bit more cautious about starting buprenorphine. But usually you'll start with a test dose of 2 milligrams and wait about 30 minutes to see if they feel better, worse, or no change. And you'll know pretty quickly when you give somebody buprenorphine if they start to feel worse, that they are having precipitated withdrawal. And if their withdrawal gets worse with 2 milligrams, then you just change gears and give them a full opioid agonist. Again, that could be that you completely switch to methadone, or if they really want to be on buprenorphine, you don't have to switch to a long-term maintenance medication like methadone. You can give them oxycodone, morphine, some more short-acting opioid agonists to try to help get them through that time of precipitated withdrawal. And then you can repeat the test dose 4 to 6 hours later. If we're giving morphine or oxycodone, those are typically more short-acting than something like fentanyl, which is itself a short-acting drug, but if they're using it for a long time, it builds up in the body and can take a while before it gets out of their system enough to be on buprenorphine. So just if they have any sort of precipitated withdrawal, just revert to giving them short-acting opioids. The second option is that you can start somebody on a lower dose initiation. Now, I would say if someone is in acute withdrawal, that you doing a lower dose initiation is not going to get them out of withdrawal that quickly. You would also, in conjunction with this, need to give them a full opioid agonist. So this is something that I think is more helpful for people who aren't acutely withdrawing. This is the patient who comes in and has recently used opioids and is not feeling any withdrawal yet. So you start with a lower dose, 1 milligram or less, and give them that every 4 to 6 hours, and then slowly increase the amount of the milligrams that you're giving so that the buprenorphine can start to bind to the opioid receptors, but not completely flood them at the beginning. So there's a partial opioid agonist and a full opioid agonist kind of competitively binding at the same time, and then you slowly change from one to the other. So this is a slower, sort of gentler way to start buprenorphine. Again, this is not typically the way that I would intervene if somebody was having really acute active withdrawal. If they're feeling very, very sick, then usually you can start with a higher dose of buprenorphine. This is giving you the kind of algorithmic approach to doing the opposite of what I just described, which is low dose, where you slowly give a higher, start out with very low doses of buprenorphine and then slowly increase them as you're giving full opioids as well, so that you're switching from one to the other. The other method that people have used is just giving very high doses, or starting with high doses of buprenorphine and just flooding the receptors with the buprenorphine. And if they feel withdrawal, just give them more and more buprenorphine until you get them out of withdrawal. There have been case reports of using this in pregnancy. I think people are often more cautious about using this in pregnancy because of the concerns about precipitated withdrawal. But if someone wants to be on buprenorphine and they are being monitored and overall doing okay, you can do this sort of higher dose, give them 8 milligrams. If they're withdrawing, just keep giving them more buprenorphine until their withdrawal subsides. Comparison of these, the standard protocol that I told you, which is start with the 2 milligram test dose and then give them a higher dose if they don't have precipitated withdrawal, is typically works pretty well in people who have mild to moderate withdrawal. They have a cal score of 8 or above. And it if the patient, this is their preference, or they have a history of precipitated withdrawal, you want to start with a test dose. The lower dose is for people who are very, very scared of precipitated withdrawal or are not really feeling much withdrawal yet. You want to start with a lower dose initiation. And then the high dose, I wouldn't recommend in somebody who's not feeling withdrawal. Again, this is someone who comes in acute withdrawal. You can start with a higher dose you can do the higher dose protocols. Again, these have not been studied in comparison to each other. There's no like randomized controlled trial. The low dose and high dose are really based on case reports of people just trying to find ways to get patients on buprenorphine. So we've just spent a long time talking about precipitated withdrawal, but I want to put it into perspective. I think this is the number one reason why people hesitate to treat withdrawal, particularly hesitate to give buprenorphine, because they're afraid that they're going to make things worse or that they're going to cause some problem in the pregnancy. So this like kind of I don't want to call it an urban legend because it's not completely untrue, but there's this idea, I think, infused into our brains that putting somebody into withdrawal when they're pregnant is going to cause something really terrible to happen. And this really comes from a couple of reports from the 70s that had nothing to do with buprenorphine. And there was one case report of one mom who was in withdrawal, left the hospital, came back, and had a fetal demise. And so they thought, they blamed that on her withdrawal. Whether or not it was withdrawal, no one knows. But that really kind of took on a life of its own, and we started believing that that withdrawal could cause fetal demise. There was also one study where they did amniocentesis and saw that there were higher cortisol levels in the amniotic fluid of people who were withdrawing. So I'm not saying that withdrawal is not a bad thing, but I don't think it's as catastrophic as it's made out to be. I don't think anybody really needs to be worrying that if they give 2 milligrams of buprenorphine and it causes some withdrawal, that's going to cause massive fetal distress. It's just not true. It's not proven. The chronic withdrawal and use cycles that we see with people that are actively using are problematic and can cause problems in the pregnancy. But precipitated withdrawal is really an acute, self-limited event that the goal of which is to get somebody into treatment. And so the immediate risks of it are really quite low. And so I just want to say loud and clear that avoiding precipitated withdrawal shouldn't be viewed, it should be viewed as a goal to keep people comfortable, to help them get through their withdrawal and into treatment, and to decrease their adverse experiences with getting into treatment, but it doesn't need to be so scary that it actually keeps us from treating people. So I love this quote: imperfect action is better than perfect inaction. And so this fear of causing precipitated withdrawal oftentimes makes people not use buprenorphine. It's really a pretty rare occurrence. It's self-limited and treatable, and it should not be used as a reason to delay treatment if you think that's the appropriate medication for them. And just remember that untreated opioid use is always the worst option. So doing nothing is the idea of like first do no harm. Doing nothing is harm. And so people really deserve to be, their withdrawal deserves to be treated, and we should be intervening. Then, sorry, I think these slides are backwards. I'm missing one. Where's my when in doubt slide? Maybe I'll get to it, but I'll say it here because it makes more sense here. I think it got switched up, but when in doubt, I just told you about methadone, about buprenorphine, about different initiation protocols. If you don't know which medication the patient wants to be on or don't know which one would be best for them, just giving short-acting opioids is always a safe option. It won't preclude them from then starting buprenorphine or methadone later if that's what they want to do once you get them out of withdrawal, because the decision about whether to start buprenorphine or methadone often has to do with patient preference, right? Do they want to be on buprenorphine long-term? Do they want to be on methadone? And sometimes when they're in really acute withdrawal and just feeling terrible, they can't even think about that or have a reasonable conversation about which medication they want to be on long-term. They're just living in this moment and feeling terrible. And so in that circumstance, or if you're just not sure which one's better, starting with short-acting opioids and giving them oxycodone, or if they can't take oral, you can give them morphine or Dilaudid IV just to fulfill that opioid deficit, to get them to a point where they are able to engage in a conversation and engage in treatment of not just their opioid use disorder, but whatever other presenting complaint they might have had. So Opioids are the only option. I will still say opioids are the mainstay of treatment. They have an opioid deficit, you should give them opioids. Um, but as you're increasing those medications, or if you have given them a decent amount of opioids and they're still having some other symptoms, there are medications that we can give for symptomatic relief. So this is a list of different treatments that can be used for symptom management and opioid withdrawal. So I have outlined the ones that, with the exception of Zolpidem, I should maybe not outline that one because it's not my favorite, but these other ones I use very frequently. So hydroxyzine is helpful for people who have agitation, restlessness, insomnia. Hydroxyzine can really help with that those feelings of feeling very agitated. And I'm not saying this like you should sedate people so that they're not bothersome. I'm saying this because that restlessness is very uncomfortable to them and hard for them to feel treated and safe and able to engage in treatment. And so hydroxyzine can help with that. Clonazepam is can be helpful to help really like the same sort of scenario. It can help with their agitation and irritability. Loperamide can help with the GI distress that they're having, and so if they're having a lot of diarrhea and frequent bowel movements, especially if you're afraid that they're getting dehydrated, loperamide can be helpful. Zofran or ondansetron can be helpful with their nausea, and then acetaminophen can be helpful with their malaise and body discomfort. We try to avoid NSAIDs during pregnancy, but acetaminophen can be helpful. Then not in this table, some other medications that I find very helpful. Actually, these top two are probably the two most common ones that I use for people that are in withdrawal, in addition to hydroxyzine. Gabapentin can be helpful with the full body aches, that malaise, that like bone and muscle pain that people are feeling. It sometimes helps a little bit with the agitation and anxiety feeling too. It is something that I would give for a self-limited period of time, just until you can get them to the point with their medication, their opioid medication to the point where they're comfortable. It's not something that I would put them on long term. So I explained to the patient that with these medications we're using to help you get through this period of withdrawal into initiation of your treatment. Clonidine is also extremely helpful. So clonidine helps with anxiety, with agitation, if they're having palpitations, if they're just feeling restless and uncomfortable. A lot of times people have sort of anticipatory fear about their withdrawal or about things are going to get, their withdrawal is going to get worse, and that sort of cycle of anticipating the withdrawal, clonidine can be very helpful with. Clonidine is also an antihypertensive, and so if somebody is having an acute hypertensive issue during their withdrawal, clonidine will help with the hypertension while you're giving them opioids to fulfill that opioid deficit and bring their blood pressure down naturally by reversing their withdrawal. I talked about Benadryl and hydroxyzine, Tylenol, and loperamide we talked about on the last slide. This is, this is a lot of words. You don't need to read this slide. I just wanted to point everybody toward this article that came out in JAMA in 2024. It's not specific to pregnant people, but it talks about caring for hospitalized adults with opioid use disorder in the era of fentanyl. And a lot of what they're talking about in this is the fact that we have been having to use higher and more frequent doses of opioids when people are hospitalized and having acute withdrawal. And it shows some of these symptoms that we talked about, tachycardia, hypertension, and how some of those can be resolved with giving appropriate amounts of opioids. So you don't have to read all these words. I just wanted to point you to this as a reference of something that you can read on your own. Oh, here it is. Sorry, I thought that this slide was backwards. So here's it's worth saying more than once though. So when in doubt, this quote, if you don't know where you're going, any road will take you there. I think that's supposed to be a negative thing, but I view it as a very positive thing in this scenario. Like, I don't know what she wants to be on long term. I don't know what's going to happen 5 days from now. I'm not sure which medication to choose. So short-acting opioids is always a reasonable choice to start with, and then titrate them to patient comfort. Again, if you're more comfortable using the CAL scale to determine if they're improving or not, that is a more like objective or measurable or trackable thing. But really, I just ask them, do you feel like you're on withdrawal? Are you feeling better? And if they're not, ask narrowing down what symptoms they are specifically and seeing if maybe we can do some symptomatic control while we're up titrating their opioid treatment. So I know this talk is quite repetitive. There are some things that points that I really want to drive home. And of course, giving people with an opioid deficit opioids to treat their withdrawal is the hallmark of this talk. But the most common response that I get when talking about giving somebody who's in withdrawal opioids is, well, they have an addiction to opioids. Why am I giving them opioids, right? Like that's what their use disorder is. And now I'm just going to give them to them. Like, doesn't that just make me their legal drug dealer? Or aren't I contributing to their addiction? You're absolutely not. And no more than somebody who is giving someone insulin is a drug dealer, right? So they have an opioid deficit and you are giving them an opioid to get them back to their baseline. Just like somebody who has diabetes has an insulin deficit and you're giving them insulin to get them back to their baseline. You're not using it in an inappropriate way. They're not getting high from it. They're not getting any sort of euphoria. They're just getting back to their baseline. And it's not contributing to their addiction because our patients, and I know the next slide says this, but our patients are actually quite savvy. They know how to um, care for themselves and they know how to get themselves out of withdrawal. And so if they're in the hospital asking for treatment for withdrawal, that's because they want treatment for their opioid use disorder because they know that they could get it on their own in another way. And so we're not keeping somebody from having addiction by not giving them an opioid. In fact, we're probably making it worse by making them get those opioids in an uncontrolled way. So remember that this is a chronic medical condition that we're treating. We're engaging in harm reduction and treating patients with dignity and respect. Our patients aren't drug seeking. I really hate that term, but sometimes people will tell me I think this patient's drug seeking. And I mean, I guess in a way, they are in the sense that their body needs opioids and they're asking for opioids, but we shouldn't view that as a negative thing. Yes, they are asking for opioids, but that also is exactly what their body needs because they have a massive opioid deficit. They're not looking to get high. They are asking for treatment to get out of withdrawal, and they're really not trying to trick you. And so I think sometimes people get uncomfortable with this idea of like titrate it until they're comfortable. But that is ultimately the goal is to get them to be comfortable. And we have to trust them that they're not lying to us and saying, oh, I'm still in pain, just so that we will give them more opioids. As I said, they're smart and resourceful. They know how to get their own opioids. They're really trying to do this in a monitored way that is the safest and healthiest for them. And they're there seeking our help. And so our judgment and our assumptions that they're trying to trick us or pulling over on us really do not work very well in our to build a therapeutic relationship. Just one brief slide about pain management. This is another common question that we get. So somebody comes in and delivers a baby, and now what do I do? They just had a C-section. What do I do? So the short answer is you continue whatever medication they were taking for opioid use disorder. And then, like anybody else, you use multimodal pain medication, try to use non-opioid analgesia as much as possible, but it is okay to give them opioids for their pain. In fact, most of the time you will need to. Most people who have a C-section need opioids for their pain. So if they are on methadone, if they're on buprenorphine, you continue those things and give them medication in addition to that. Now, if someone comes in and they are acutely withdrawing and then they go through a C-section and now you haven't quite gotten them out of withdrawal yet or onto a maintenance dose of medication, and now they also have pain, the answer is, again, just keep titrating up their opioids until you get them comfortable both from their surgical pain and from their withdrawal. And so those things are going to get a little cloudy, like which one am I treating right now, their surgical pain or their withdrawal? And in some senses, it doesn't matter because both of those things need to be treated. And if they need opioids, the whatever dose of opioids they need to treat those is what we need to be providing for them. So again, I'll say don't stop. If somebody is on medication for opioid use disorder, don't stop that to give them pain medication. Even if it's buprenorphine, it's a partial agonist, you can still give them their opioid pain medication on top of that. So you give them both. Because if you stop their medication for opioid use disorder, their longer term medications like buprenorphine, it's very destabilizing and increases the chance that they will return to use after leaving the hospital. This is a quote from a patient. This happened last week. This is my patient. And I did her C-section and was not in the hospital for the weekend. And she was not given pain medication. Someone told her, for as much education as we do about this, someone told her, you can't take buprenorphine and oxycodone because it's going to block it. So she got very frustrated. understandably, because her C-section pain was not being treated, and she started refusing her buprenorphine. She refused her Suboxone so that they would give her oxycodone. Eventually, they give her oxycodone, but now she's not on her Suboxone anymore. And when I came to see her, we had a long talk about it, and these are like verbatim what she told me, and she said I could share it. Y'all are lucky I didn't have no money, or I would have gone outside and bought it myself. This is what makes people relapse. So again, the point is us withholding opioids is not helping somebody in their addiction. In fact, in some ways, it's probably making it worse. So then considerations so we're talking, this talk is really mostly about acute management, but we do want to be thinking, okay, we got this under control, you're in the hospital, but now what are we going to do after you go home from the hospital? So just a reminder that overdose death is the #1 cause of maternal mortality. These are numbers from the state of Maryland. It's the #1 cause of death during pregnancy and the year postpartum by an order of magnitude, much more than hypertensive disorders, than hemorrhage. It is the #1 cause of death. So preventing fatal overdose should really be top of mind at all times. And we know that medication for opioid use disorder works to prevent fatal overdoses. So this is showing during pregnancy and then up to a year afterwards, the rates of overdose deaths. And the orange are those who are on pharmacotherapy. And so the overdose, it doesn't completely stop it, but it certainly does decrease the rate of overdose death, people who remain in treatment after delivery, postpartum. So just a word about opioid overdose. These are some of the symptoms of it. We should be counseling our patients and their family support system, whoever else is going to be around them, about signs and symptoms of opioid withdrawal. Especially in the postpartum period, people can get really sleepy sometimes, and because they're up with their baby all night and for 100 different reasons. And so really educating about like what is opioid overdose, what does it look like, and when would you really need to be decreasing the medication that you're taking, or have Narcan. And so also I'll talk about that in a moment, but sending people home with Narcan and educating their family members or anybody else that is going to be around them about signs and symptoms that they should be aware of. Naloxone is used for reversal of opioids. It's a complete opioid agonist, and so it can be given if somebody is in acute withdrawal. Its widespread distribution has been shown to decrease overdose deaths, and in our hospital, we typically give it to anybody who is going home with any prescription for opioids. You can write a prescription for Narcan, insurance will cover it. And there are also naloxone standing orders at most pharmacies. So pharmacies should be able to dispense it even without a prescription. But if you write a prescription for it, usually Medicaid will cover it with at most $1 copay. Also, I think one of the hesitations to start treatment sometimes is I don't know what to do after, like I'm not going to manage this person's opioid use disorder long term, but that's okay. You don't have to. You're just taking the first step. So when somebody is discharged from the hospital, if you don't have the luxury of having an addiction treatment service inpatient in your hospital that can help guide you, you can go to findtreatment.gov, type in your address, and it will show you all of the treatment practices around your hospital, around their home address, and you can just print those out for them and give them all the options. And it breaks them down based on, are they residential, are they focused on mental health, and what options there are in each one of the treatment facilities. And then lastly, I said, when in doubt, give short-acting opioids, and I do mean that, but also when in doubt, please reach out and call us. We're happy to help anytime. And so you can call the warm line Monday through Friday. We'll try to call you back on the same day. And we also have an echo clinic, which is once a month. We meet. There are other providers across the state, and we meet together and present cases of patients that anybody who is there has taken care of in the last month, and just talk through different strategies. And so it's not me lecturing you like in a webinar. It's a really conversational meeting, and you can bring questions or concerns that you have there if they're not acute, not like I need to treat this person right now, but I had this scenario, what would I do next time? We're happy to have you in our echo. And that is all.
Thank you so much, Dr. Mark. As always, that was wonderful. So we do still have time for questions. If anyone has a question, you're welcome to put it into the chat or you can unmute yourself, whichever you prefer. Um, I'll take this time to kind of, again, go over the process for earning credit. So if you have questions and think of them, again, please feel free to put that in the chat. But in the meantime, again, after today's session, your attendance has been marked as present if you have been on for the full duration in your Oasis portal. You can go in, you can access your survey. You need to complete that evaluation. And then you can access your CME or your CEU certificate immediately from Oasis. And you do need to do that survey within 7 days in order to get credit. I do see someone's hand is raised. Caroline, if you wanted to unmute or put your question
Yes.
in the chat.
Thank you. This was fantastic, and I really like the messaging too around precipitated withdrawal. So thank you very much. I'm an OBGYN at Johns Hopkins. I do a lot of work with jails and
Mhm.
encouraging them to um, uh, provide standard of care for pregnant and postpartum folks with opioid use disorder. And two of the biggest barriers, cultural or attitudinal barriers, are one, we're substituting one drug for another. And so I appreciate the messaging around that. But there is a unique setting, or the unique setting of jail or prison is that there is a lot of more diversion there than in the community. And so there are understandable safety concerns. So I guess one question is this something that you have um, uh, any experience with or additional messaging recommendations in this setting that's just a little different where those concerns, I don't want to say are founded, but you can understand a little bit more of that perspective. And then the second thing is I've seen a lot of fear in these settings of precipitated withdrawal because the simplified messaging for people working in jail sometimes is that withdrawal is harmful to the fetus with some caveats that gets them to listen. And so too much of that messaging makes them worried, anxious about the precipitated withdrawal. So I do appreciate that it's not as big of a deal and that messaging. So thank you.
Well, thank you. I'll take the second question first because it's easier, or easier for me to, I have a more direct answer for. So I agree. It sounds like double talk that the reason that we want people to be on medication for opioid use disorder is because it is safer for them in general, right? We know this in non-pregnant people. But in pregnancy, when someone tells me, I don't want to be on it because I don't want my baby to get this medication, my response is, well, actually, it's worse for you to go through withdrawal. And also, you're more likely to return to using. And so the messaging is true that the chronic cycle of use and withdrawal, and then use and then withdrawal, and then use and withdrawal, that is harmful in pregnancy. And so you're right, we've been pushing this message of like, it's you don't want to just keep going through withdrawal in pregnancy. It causes increased stress and problems for the pregnancy. But then that gets mixed up with the messaging about precipitated withdrawal because again, understandably, we're taught like we would prefer that pregnant people not go through withdrawal if it's better, it's safer for the baby to go through weaning of medication after delivery than it is for mom to go through withdrawal during pregnancy. And again, part of that is the risk for the pregnancy, but a big part of it actually is the risk of returning to use, which is the problem. But because that message gets kind of mixed up, and so then people are like, well, I don't want to give this medication because I'm going to cause withdrawal, and you told me withdrawal is bad. But then they do nothing, and then withdrawal happens on its own. So I think part of this is the like again, the first do no harm. It's somebody reframed it to me to like do less harm, right? So doing nothing is harmful. Treatment, maybe you're going to cause a little bit of withdrawal, but that's better than no treatment, and it's manageable. And so yeah, it's there's not a I understand where the confusion comes from. So I don't know if I answered anything or just sort of validated what you were saying, but and then separately in jail settings, I'm not super well versed. I know that there are mandates about what they have, and then there's like the actuality of what exists there. And so oftentimes people aren't being given a lot of choice for whatever reason. So I think if there is a pregnant person in a jail setting and they are having difficulty initiating a medication because they can't give it to them more frequently because they can't just give it to them and let them have it in their cell, it has to be monitored, it has to be given to them and supervised, and they a lot of times don't have medical staff to do that. So I think having them come to the hospital and do it in the hospital, if that's the only option, is honestly probably better and safer for everyone.
Thank you so much. We do have another question in the chat. How does the extra medication affect the fetus?
So I'm assuming the extra medication you're asking about opioids, and I don't want to say that there are no risks to opioids in pregnancy. There are risks to opioids in pregnancy. But the biggest risk is this like destabilization of the environment and people using opioids, and again this like chronic cycle of use and withdrawal, and all of the other things that destabilization of opioid use disorder does. And so a person who is actively using is less likely to be attending prenatal care, less likely to be eating well. They have much higher levels of stress. Usually they're often in unsafe situations and are more likely to be in violent situations and have a lot of other health risks. And so I don't mean to minimize and say that opioids don't have any risk in pregnancy, but untreated opioid addiction has a much greater risk just because of all of the other health risks to the pregnant person. So increasing opioids during pregnancy, there's not a direct line between any level of risk and the amount that they're taking. And so, for example, babies whose moms take medication for opioid use disorder do have a risk of going through withdrawal after delivery, and that is something again that is time limited and treatable, and if treated appropriately doesn't seem to have long-term risks to it. But there's no direct line between like this is how much methadone you're on and this is how likely your baby is to have withdrawal. It really is very person dependent, and probably some of that has to do with genetics, some of it has to do with how it's filtered through the placenta differently in different people. Opioids in general have some risk, but opioids in a controlled and monitored and prescribed way that we know what they're getting, and it is a steady dose and it's not contaminated with anything, and they're not having to be in really unsafe situations to get it, or use all of their money and not have safety, or having it. Sorry, I lost my train of thought in that run-on sentence, but having it in a more stable way is much safer, of course. So I don't know if that answers the question really at all, but I guess I don't mean to diminish the question, but anytime we think of any risk of anything during pregnancy, we have to think of the risk of the alternative, because the option isn't opioids or no opioids. The option is opioids or severe withdrawal or returning to uncontrolled opioid use and destabilizing opioid use disorder. And so there's not really a like answer number 4, which is just no opioids, no withdrawal, and then everybody's okay. So that's not really the comparison group, if that makes sense.
Thank you, Dr. Mark. We do have a minute for another question if anyone has anything. In the meantime, as Marciel included our information with Max and Max for Moms, if you do have any other questions that you think of after today's training, you can contact us anytime. We can definitely connect you to Dr. Mark, and happy to answer questions. And again, I'll just go over for CME and CEU, you'll be able to go into Oasis now, access your evaluation, and then you'll be able to download your CME or CEU certificate. And if you do want that credit, you do need to do that survey within 7 days from today. So I know that the time is at 1, so we can wrap up. And a question about accessing the recording. Yes, it will be posted to our website within 1 week from today. We will also be sending everyone the slides, but we just need some time to work out with Zoom in order to get the recording, so it will be put on our website. So thank you, everyone. Thank you so much, Dr. Mark. As always, a wonderful presentation. And thank you, everyone, for taking time out of your busy day and afternoon. And I hope that everyone has a great rest of your day.
Thank
Thank
you.
you. Take care.